Welcome to the Oral Surgery Fight Club podcast. This is a collection of mock cases in the field of oral and maxillofacial surgery in a question and answer format conducted on Zoom. Enjoy. Yes. This is going to be fun. I always enjoy surgeons' cases because they're like a comprehensive review.
Yeah, you know it. Okay. If we run out of time, Ryan, let me know. Carl, you ready?
I'm good on time for.
I guess I'm ready.
Right. So, 35-year-old woman coming in for implant placement under sedation. She has diabetes type 1. She takes 4 units of short-acting before meals, 28 at night. What's diabetes, Carlin? What are the kinds, you know?
So diabetes is diabetes is an acquired condition where there's a dysregulation of glucose, and there's two types. There's one where you're not producing enough insulin. You don't produce any insulin properly, and then there's a type 2 where you're not. You don't produce insulin for the amount of glucose that you're intaking.
And how do you diagnose the diabetes?
So you can take HbA1c, hemoglobin A1c, and if that's above 6.5, you have diabetes. Or you can take fasting glucose over 120, or random glucose over 200.
Okay. So what concerns do you have for this patient, diabetes type 1, before your surgery?
So if she's undergoing IV sedation, she has been in PO for at least 6 to 8 years. So she probably shouldn't be taking, she shouldn't take any of her short-acting insulin, and she should probably have, she should have her dose of her long-acting insulin the night before.
Okay.
Patient's early appointment. They have taken insulin.
Okay. Are you going to do any other perioperative preparations before you put this patient to sleep?
I would ask her how she's feeling. If I have the capabilities, I will take a glucose. Currently, I don't do that at my practice, but it is an option.
Okay. All right. So you hold her morning insulin, tell her continue her basal. You check her blood sugar. That was fine before surgery. Procedure went fine. She calls your partner to your office 2 days later, and she's complaining of nausea, vomiting continuously since procedure, and she would like something other than Zofran that you called in previously. So how would you like your partner to handle that call?
I would ask her, has she been eating? What's her diet like recently? Is she try to figure out if she's dehydrated, if maybe she needs a little bit more management than just PO.
Okay. Yeah, she said she hasn't been eating too much since it was kind of hurting her after the procedure. And she decided not really to take her insulin accordingly because she wasn't eating much. What else do you want to do for her? She's still nauseated.
I recommend that she sees her primary care physician.
That's Saturday night. She says she won't be able to get him in until Monday. So your partner decides to get her in the office just to evaluate her. She appears to be fatigued. She has dry mucous membranes. She's got fluty breath. I'm measuring her blood sugar. It's 280. What would you like to do next?
Start around some fluids, and give her some, get some vitals on her. see how much of the insulin she's been taking, what she's been eating, and fluids. I'd probably give her some. I mean, 280 is not that bad.
You start on normal ceiling. Yeah, she's feeling a little better, but still kind of really drowsy. She hasn't been really taking any insulin, she said, because she hasn't been eating. Anything else you would want to do for her?
Probably refer her to the emergency department.
Okay.
Her sugar, you said, was 280. I'm giving her fluids.
What do you suspect is going on with her once she goes to ER? What is it that they're gonna look for?
They're probably, she's on her way maybe to DKA, but she diabetic ketoacidosis, but that should be a glucose level over 500, and she's at 280. I think she's just dehydrated. The sugars are high. She's not.
What is DKA?
Diabetic ketoacidosis. It's a glucose level that leads to electrolyte disbalance.
Okay. So you send her ER, they check her blood sugar. It's now over 300. She's found to have ketones in her urine, and her ABG is the following. Can you interpret that ABG?
Yeah, so she is acidotic.
Okay.
And yeah, that's like that. She's acidotic.
Is it a respiratory or metabolic?
It is metabolic.
Okay. With metabolic acidosis, is there any kind of formula that they can use to calculate if there's anything else that's causing this?
Not that I can think of.
So your patient's A9 gap is shown to be 40. Is that normal, high, or low?
I'm sorry?
Her patient's her N9 gap was calculated to be 40 in the ER. Is that high, low, or normal?
N9 gap, that sounds high.
And what's responsible for that?
What's responsible for that?
Yeah.
I'll tell you.
How do ketones get generated in somebody's DKA?
Breakdown of not glucose. Breakdown of glucose? I'm not sure.
So this patient's management, what does it consist of once she's in ICU?
So they're going to give her insulin. They're going to give her fluids. They're going to put her on her sliding scale. They're going to give her different electrolytes, including potassium, and monitor her blood glucose and her mental status.
And why would this patient require potassium replacement?
I can't recall.
All right. Well, that's it for this case. I know it's kind of short, but
Oh God.
I've got another one after this. If
That's
you
pretty
want.
good.
Is
If
it?
you
I
want.
feel like I killed her. I actually
you-
did not review DKA, so
Yeah. I mean, starting off with diabetes, yeah, type 1, type 2. 1 doesn't produce insulin. 2 is just either insufficient or resistant. You write about diagnosis, A1C below, above 6.5 or above 200 random, or above 126 fasting. I guess when asked what are your concerns for this type of patient, you always think about decay and hypoglycemia, being prone to infections. Those are kind of concerns and goals, right? To maintain normal glycemia, staying kind of like high hundreds, 140s to 200s. That's the goal. Blood sugar in the morning of procedure, you would definitely want to have a way to measure that before you start the case. Holding her pre-meal insulins, but continuing basal. It's a good strategy. You want to do early morning appointments, and check on her afterwards. Make sure she returns to her nutrition and insulin intake. And this is exactly what happened. 2 days later, she's still nauseated. She's thinking maybe it's related to anesthesia. I guess that's a little trap here, maybe trying to get you to think that she's still having just post-surgical nausea, vomiting, but indeed that
2 days post-op, that's
2 days post-op, and the Zofran is not working. She's asking for more antiemetics. So you could think about like what are the antiemetics to prescribe, like promethazine or Benadryl. But yeah, the important thing is to bring her in the office. Even if it's a Saturday night, I mean, over the phone, it's I don't know, Ryan, correct me if I'm wrong, but in these situations, it's always safer just to say bring her in for evaluation.
Yeah,
What you bring?
If you have any question about it, that's the safe answer. And they'll probably push you that way if you don't go that way first. So
yeah,
I don't think the way to get out of it.
Right. So you definitely, you said it right. Check how she's been eating, what insulin she's been taking, and she's responding that she hasn't really done none of those. Check her blood sugar; it's high, 280. All right, it's not quite 500, but she's on evaluation, fatigued, and got dry mucous membranes, has fruity breath. So that's kind of like a key sign that she's going to DKA. Definition. Well, first of all, you want to get her in ER. That's an emergency. So she's going to ER to get some more blood work. They're going to do BMP to look at her electrolytes. Does she have that anion gap? They're going to check her ABG. Does she have that acidosis? And of course, key to diagnosis is ketones in urine. For DK, that has to be present for the diagnosis. ABG or given indeed shows low pH, that's acidosis. Decreased bicarb, so that's most likely your metabolic acidosis. And anytime you have metabolic acidosis, it's like an anion that's causing this condition. So somebody just been drinking, I don't know, some unapproved alcoholic beverages, we call it, antifreeze fluid. Or she's having a decay. This is what ketones do. Normal anion gap is 20, so hers is 40. That's above. So there's something in the bloodstream that's causing this metabolic acidosis, and urine ketones will show that. Decay results, basically ketones come from your cells breaking down fatty acids because they're starving for glucose, so they're going into the kind of gluconeogenesis cycle and produce the ketones going into the bloodstream. And it's something that develops rapidly with nausea, vomiting, abdominal pain, lethargy, obtundation. So management indeed is going to be IV fluids and IV insulin, transitioning to sub-Q insulin. And these patients are prone to hypokalemia because anytime you give insulin, that drives potassium into the cells. So that's the main reason they get replacements for potassium. You want to closely monitor this potassium and blood sugar levels for this patient next couple of days in ICU, and transition to sub-Q insulin. She's going home. She does well. Yeah. All right.
It felt worse when you're going through it, but I was like, oh, I did get some of the things.
Yeah, I mean, it's just the way I form questions.
Where ketones come from?
I know. I don't know. I set it up in a way that's probably not very straightforward. Maybe a little bit tricky, probably.
My husband said it was good.
Okay.
I think you did fine, Carla. It was a good case too, Serge. Like diabetes and like some complication of it is a fair thing.
Yeah. Also the nausea and vomiting too. Kind of goes one way instead of another.
Right.
I think the metabolic versus respiratory acidosis that might be a bit of a stretch to see on the exam, but I mean, if you're,
I was gonna say, I thought you were gonna say,
it might be. I don't think
I thought you were gonna say deep pool, man. Okay.
It's better to test your limits and like how far you can go.
Gotcha.
'Cause on the real exam, they might. I have a feeling if you got a question like this, you're in a good place.
In a good place. I gotcha. All
Yeah.
right.
Yeah. That wasn't too long though, right?
No, that was a full, I don't know, 10 minutes or so.
Oh, okay.
Nice. Okay. All right.
It'd be a fair case.
Hey yo, I gotta sharpen my swords for the oral boards. I learned him from Patel and he's the Lord. And I'm his protege, you know I'm gonna slay all these motherfucking questions today. Cause I got the sound bites, they're gonna make these old men go ooh, ah, like some afternoon delight. Yo, I got these questions in my sight and I got the answers. Yo, my answers is so ill, they give you canker sores.
Thanks for tuning in to Oral Surgery Fight Club. For uncut episodes and sound bites, go to osfightclub.com.